afternoon, everyone. It's a great pleasure to welcome you to the EULAR 2022 press conference here in Copenhagen. After 2 years of virtual press conferences, it's especially nice to see so many of you interested in our conference, in our program. Today we would like to present to you some of the highlights of EULAR 2022, some of our initiatives, programs, but also some highlights from our scientific program. So I would like to give the word to our President, Annamaria Iagnocco, who will first start with a short introduction of EULAR and especially the occasion of celebrating the 75th anniversary of our Congress.
Thank you. Thank you very much, Carina. Thank you all for coming here today. And it is a big pleasure for us to welcome to this Congress. As you know, this is a very important Congress for us, representing the first hybrid Congress ever for EULAR, because after 2 years in a row of virtuality due to the pandemic that, of course, limited our presence in venue, we had 2 years in a row a Congress that was completely offered online. We are now in Copenhagen, and in Copenhagen we thought it was the best way to offer a new experience, offering both a Congress in presence and a Congress in a virtual format for those who cannot attend. Indeed, still now, we are facing many challenges in our continents, in our world, let's say. Still, the pandemic has not completely come to an end. And also we have these conflicts in Europe that limit the transportations, the flights, the traveling for many individuals. For this reason, we decided to offer a hybrid event. So for those who can attend, they are all very welcome. But for those who are at home or in their offices, visiting patients, following up with their patients, and also for those patients who couldn't travel, for the health professionals that had limitations, so for the community in general who want to be at home, there is still the possibility to attend virtually our conference. But we also celebrate the 75th anniversary of EULAR, and we decided to come back here in Copenhagen, where the first EULAR Congress took place in 1947. If you were attending our opening ceremony, you saw that half an hour ago, you saw that at the end of the opening, we opened also the cake. We showed the cake. That is a cake that is here in the EULAR village, and it is representing our celebrations for our organization. Our organization is 75 years old, but it looks much younger. It's energetic, it's vital, it's full of ideas. And with the complete restructuring of our governance, our organization is extremely flexible. We have our 3 pillars representing the national societies of patients, of health professionals and the scientific societies. And these 3 pillars work together in collaboration and in very close interactions. We have our communities, the community of patients, the community of young rheumatologists, the EMUNET, the community of health professionals, and the community of the pediatric rheumatologists. And all these persons work together in the concept of this EULAR family. And we have the committees that work for making projects, for developing projects, and for meeting the aims and the strategy of EULAR. Every 5 years, EULAR develops a new strategy, and these strategic aims are the aims that our project should go and should have the direction for optimizing the work of EULAR. So each committee, the research committee, education committee, quality of care, advocacy committee, education committee, those are the 5 committees that develops projects, work for those strategic aims. And you see that many projects have been developed over the last years, and many projects are coming. So all this is in the idea of a big family, what we call the EULAR family, because we think that working all together is much better than working alone or in small departments in an isolated context. And so this idea of collaboration, inclusion, equity, meritocracy, they represent the basic principles of our work. We have a fantastic team of people working all together. We have a fantastic EULAR office led by an extremely successful director, executive director that is sitting there, our Dr. Julia Rautenstrack. So she gives the direction to the office. We have a board that is there for having an overview and leading our organizations. And we have our communities, our council, we have our committees, we have our people working all together with the aim of supporting patients and improving the quality of life, the permanence to work of our patients, and the management of people with rheumatic and musculoskeletal diseases. And you see that we work all together for meeting those aims. So really welcome to this Congress. This is extremely important for us, and thank you for coming.
Thank you, Annamaria. I suggest that if you have any questions to Annamaria, we can ask them directly, and then otherwise we will pass on to our next speaker. So we have questions directly after each presentation. If you have a question, please raise your hands and also briefly introduce yourselves. And if not, then we will move on. Next, I would like to introduce Professor Iain McInnes, the EULAR past president, as well as Professor Dirk Elewaut, which is the current chair of the research committee. And they will present an article about the EULAR Research Centre, which is very close to my heart, because that's also the department that I'm happy to manage as a project manager. And we recently launched a new article about our activities. So thank you, Iain and Dirk.
Well, thank you very much indeed. Good afternoon, ladies and gentlemen. 120 million people suffer from a rheumatic and musculoskeletal disease in Europe. 120 million people. It's the commonest cause of work loss, disability. It is a set of more than 200 medical conditions for which there is currently no cure. And yes, we have had a wonderful 2 decades of new medicines, of progress, and then of transformed lives. But we have a long journey to travel on behalf of our patients. Annamaria has introduced to you the range of activities that EULAR undertakes. And what I will introduce to you today with my friend and colleague Dirk is quite a new initiative, the EULAR Research Centre, which aims to bring equity of access to world-class research across Europe. It aims to bring excellence to the quality of research in the rheumatic musculoskeletal diseases as their trials and other investigations are performed across Europe. And it aims ultimately to bring about remission and improvement in quality of life of our patients. Carina mentioned an article that we have prepared, and I commend to you. It is being published even as we speak. I think it's out today or tomorrow. And in this, we have described the inequities of access to research. It will be published in RMD Open. It is a collaborative article that brings together the views of several members of the research committee. It lays out the rather unequal distribution of research productivity across Europe. And it sets out a vision for a solution, which is our research centre. The Research Centre has been active for the last year, driven by the incredible work that Carina and her colleagues are doing in the office. We offer research consultation services, for example. This is an opportunity for rheumatologists, health professionals across Europe who maybe do not have access to immediate resource to support research, and we match them with experts working in those areas of Europe who are well provided for. And so experts meet future experts, partnership occurs, and important questions are answered. We also are moving to new, highly exciting initiatives. I will mention two, and then Dirk will talk about two more. The first is, and this was mentioned by our President-elect during the opening ceremony, the desperate need for data, and more importantly, the processing and understanding of data. And so we are launching a Europe-wide database that is ground level up. The data will be contributed by our patients. And those data will describe the symptoms that they have, the impact on their quality of life, the disease that they have, the effect that it is having on their lives. And we will follow them every 6 months for as long as they're prepared to contribute data. We envisage thousands of people contributing to this new database going forward. And we learned during COVID that data entered by people who are directly affected by illness can be hugely impactful. You will hear from Professor Pedro Machado later in this press conference, I think, about the impact. He's nodding vigorously at me, which is very reassuring, about the impact of ground-level data in determining decision-making in delivery of healthcare policy. During COVID, that was an imperative for fast decisions, and EULAR led the way, as you will hear. And so we're going to extend this model over the next 5 to 10 years to create a world-class database to inform the unmet needs and to inform the critical questions that must be answered if we are to bring remission and cure to our patients. Alongside that, a second key initiative is something we are calling RheumAffacts. This is, if you like, an encyclopedia, a common landing ground of the necessary information that will allow you, who communicate about health-related matters, and we, who investigate rheumatic musculoskeletal diseases, to have a common point where information is readily accessed. How many people have disease? What is its impact? How many people are disabled? How many people are not working? How many work days are lost to the economy? What is the cost of rheumatic musculoskeletal disease to national and international economies? RheumAffacts will gather all of that and become a common, openly accessible resource for you and for us as the investigating community, health professionals. Remember, patients are at the very core of research. Patient research partners, again, pioneering within EULAR, and of course the professional investigators in medical and life sciences and health professional societies that you'll hear about shortly from Thea. And so a ground-level database, transformative in our understanding of the impact of disease, an encyclopedic place where the RheumAffacts come together, creating an environment in Europe for world-class research to occur. But we're even more ambitious than that, and I'm going to ask Dirk to describe two further initiatives just approved at this Congress, which will make an extraordinary difference going forward. Thank you, Dirk.
Yes, good afternoon. My name is Dirk Elewaut. And so the two projects that we actually have embarked into are quite revolutionary, in the sense that what we want to do is to bring new medicines to our patients and new way how we treat patients faster, and harmonizing this. So the way we have thought that this would be facilitated is by organizing a European Clinical Trial Centre under the umbrella of the EULAR. And we think that that is one of the ways how this inequity of access of patients can be avoided. And so what we will do is we'll set up centers based on expertise with the quality label of EULAR endorsement to come to accredited centers where we can actually do clinical trials focusing on areas of expertise and knowledge. And this will be integrated with some of the projects that Professor McInnes already highlighted with databases. So the idea is basically to bring new ways of treating patients earlier, harmonizing this across Europe, and actually be also capacity building. And because imagine some of these rheumatic diseases are rare diseases, for example, and there you need a whole critical mass to actually have sufficient numbers. So that is a typical example. But also in frequent diseases, we think there is still high unmet medical need for new ways of designing clinical studies. And this initiative is called ENTRY. And we'll, as the word says, we'll enter with the big door and trying to have a world-class clinical trial center that will be organized according to the umbrella. And so one of the elements we think is also important is that it will not be only clinical trial, it will integrate clinical databases as well, but it will also match with emerging technology, and that is the second initiative. We have seen, especially over the past years, a lot of new technologies that have entered the field of biomedicine. Some involve, for example, what we call looking at the genome, but next thing transcriptome of immune cells in tissues. And these technologies are very rapidly evolving. They are very powerful. They actually facilitate to track this in combination with trials to precision medicine, which is actually a word that is very fashionable in cancer medicine, but that we really want to integrate into rheumatology. And we think we are in a very strong position because a number of world-class centers in Europe are there. We want to integrate the knowledge of these centers, and we want to harmonize so that we actually really have capacity building. And when we are talking about doing such types of technologies, that we are speaking the same language across Europe. Okay. We should not see this as a project that we will have results immediately within 1 year. It's actually really a long-term ambition, but we have actually a stepwise approach, and we have initiated this, but it's really moving to the future generation of rheumatology. It will also make rheumatology more appealing, not only to the physicians, but also for patients, to integrate this, to really have access to things like precision medicine, to really have a more targeted approach for the patients in the next decennium. I'll maybe stop there, and if Iain wants to add on, otherwise I think we can have some Q&A.
Yeah, thank you, Dirk. Just to conclude, what we imagine is a long-term vision where the enormous challenge that RMDs set society will provoke a response not just from individual investigators, but from a community working together to common purpose, using vehicles that we are creating in EULAR. It's that common purpose. And our day starts and finishes in EULAR with our patients. They expect us to work as an integrated team. It would be very surprising to them if we said, no, the doctors work here and the scientists work there and the health professionals work here. And EULAR will not see this happen. We will bring people together to answer the most important questions of our time. Thank you very much indeed for listening to this part of our presentation. And we would be very happy to answer any questions that you have.
Any questions to Professor McInnes or Professor Elewaut? This is the last chance because unfortunately both of them have to leave us for another session they have to attend. So they cannot stay until the end of the press conference, but... Yes.
The only thing to say would be the article is open access. It is RMD Open, one of the EULAR journals. And when you have a chance to look at this, please, and I'm looking at our responsible officers, I think we would be happy to listen to any questions or commentary around the article in the time to come. It is critically important that the message is transmitted of the importance of the rheumatic musculoskeletal diseases in global society. They have been too long ignored. This document lays out very clearly what the imperatives are for our next steps going forward, and I do commend it to you for your attention. Thank you.
Thank you, Iain. Professor Pedro Machado from London. He's a rheumatologist and he is the lead of the EULAR COVID-19 registries. Thank you very much for being here.
It's my time to speak now.
Yes.
Okay. So what brings me here? So at the beginning of the pandemic, our patients and the doctors and all the healthcare professionals, they were very worried with our patients because potentially they could be at risk of severe disease and severe outcomes of SARS-CoV-2 infection. And the reasons for that are various. One, because these patients often have an underlying immune dysfunction, so the immune system is not working properly. Number two, often they're taking drugs that interfere with the immune competence of their immune system, so immune modulating drugs or immunosuppressive drugs. And third, our diseases, many of them are diseases that affect various organs or systems, so the skin, the lungs, the bowel, the joints, the heart, etc. And therefore, a significant number of comorbidities can be directly related with the underlying rheumatic disease. So because of all these reasons, there was a lot of concern about our patients, and there was a need to rapidly collect data from patients with rheumatic diseases that had developed COVID. And in around 2 weeks after initial discussions were triggered via Twitter, after 2 weeks we had set up a registry to collect data from patients with rheumatic diseases and COVID. This was done in a partnership with the Global Rheumatology Alliance. So EULAR collected data from all the EULAR affiliated countries, and the Global Rheumatology Alliance collected data from other countries in the world. And we've now collected data from more than 20,000 patients globally, around 50-50 distributed between what EULAR has collected and what the JRA has collected. And these data have really informed the management of patients with rheumatic diseases. We were able to demonstrate, for example, that many of the drugs that we use in rheumatology, including many of the biologic drugs that we use, are actually quite safe in the context of SARS-CoV-2 infection, probably from one particular drug, which is a drug that interferes with B cells, and we were one of the first ones to show that there might be an issue with this particular type of drug. It's called rituximab. And we are also able to show that many of the common risk factors or factors that are associated with the worst outcome in the general population are also the same that are associated with the worst outcome in patients with rheumatic diseases. So age at the top, comorbidities, cardiovascular disease, obesity, diabetes, chronic kidney disease, chronic lung disease. And we also found something that I find particularly relevant, is that if patients are more active in terms of the disease. If the disease is more active, if the disease is not sufficiently controlled, they're more likely to have a worse outcome of the infection. And in a pandemic period when we saw a lot of patients with delayed consultations or their appointments even being cancelled, I think this highlights the need to monitor these patients carefully, to find alternative ways of offering these patients the monitoring and the care that they deserve. And if we were able to clearly show that controlling the disease better will lead to better outcomes also in the context of COVID-19. We're able to do this at the more global level in terms of all the patients with rheumatic disease, but then as time went by, we were able to generate data for specific conditions. So we've done this for patients with rheumatoid arthritis, we've done it for patients with lupus, systemic sclerosis, etc., etc. And for example, at this meeting, you'll be able to see data for patients with spondyloarthritis, which is a specific type of disease that affects the axial skeleton predominantly, so the spine and the sacroiliac joints, but can also affect other joints. And we're also able to join efforts with other groups from other specialties, including dermatology and colleagues from gastroenterology. And for example, at this EULAR meeting, you'll be able to see an analysis that was performed in a combined data set of patients with spondyloarthritis and psoriasis. And again, for example, in that data set, we looked at drugs that are specifically used for this type of conditions. For example, biologics like interleukin-17 blockers, IL-23/12 blockers. We looked at the Premilast, among others. And again, similar findings, we were able to show that these drugs are actually quite safe when given in the context of COVID-19. So I think this effort illustrates the power, the strength of the entire community of not only patients with rheumatic diseases, but doctors, allied health professionals, and it's really quite humbling the way that the community reacted and contributed with data, even despite all the challenges. I'd like to finish just with a big thank you to all the rheumatologists, all the patients, all the epidemiologists, everyone that has contributed to this effort. Thank you.
Thank you very much, Pedro. And it's also a great pleasure to have with us Elsa Mateus, who is the Vice President of the Patient Representatives of EULAR, and she's also the board representative of the Portuguese League Against Rheumatism. And Elsa, you are also involved in the COVID-19 registry in the project, so please share your view on this.
Thank you. I think I would like to highlight the crucial importance and relevance of this initiative and the EULAR COVID registry, because it was very important for patients at a time that no one knew anything about this new disease, and due to all the uncertainty and all the circumstances that people with RMDs across all over the world were having and feeling. So it was very important to have this data collection and to produce some evidence that could support reliable information regarding disease management, regarding risk factors, and also in recent times regarding vaccination. All these materials, I should say, at the national level, for instance, they were very useful to help patient organizations to put RMD patients as a priority for the vaccination process. And this was quite useful also to provide some more protection and some more reliability for our community. So I think The EULAR COVID registry, all the work around and all the outputs are very, very relevant for the patient community, not only for the scientific side, but also because of the lay summaries and all the production, all the outputs that are make it possible for patient organizations across Europe to translate and help the information to get through to the patient community. So it was a very relevant project, and patients were also contributing to the project and providing the input and making sure that the outputs were really meaningful for our real lives. So this is what I had to say about this. Thank you.
Thank you, Elsa. Thank you, Pedro. So you see, this is a big project. It's still ongoing, and many publications, many projects have followed this registry, these registries, because we also have the COVAX registry. Do you have any questions to Pedro or to Elsa? No questions?
There's a question.
Oh, there's one, please.
Hi, this is Jeff Evans with Medscape Rheumatology and MD Edge Rheumatology. I'm just wondering, what are the next steps you plan to take with, that now that the registries are closing, how do you plan to go ahead with further analyses of patient level data, or, looking at the various COVID variants out there and just other factors that, you'll need to look at in the future?
That one. So obviously, this type of registry and the way it was established, it has some limitations, right? We're not able to collect longitudinal data. And we're now at a point in the pandemic where we really need granular data about variants, about the vaccines that were administered, the response to those vaccines, B-cell response, T-cell response. We really need very granular individual level data, prospective data. So I think now it's a time where we really need to focus on very detailed longitudinal data collection that includes the study of the immune competence of the immune system. That's the reason why we're closing the registry. It had its role, but now the focus should be shift to something else, and that's what EULAR will be doing. We will still be collecting data for the COVAX registry, so that's the vaccination registry, because we think there's still research questions that we can ask, that are questions that are relevant, and then we can interrogate that database. And there's some analysis that we're going to do with the COVID registry. Those analyses are ongoing. But I think in the future we should really focus on getting granular longitudinal data from patients with and without COVID that have been and have not been vaccinated with 1, 2, 3, or 4 doses, etc.
If I may just add to this, because it's referring to what Iain and Dirk were presenting earlier, this idea of a longitudinal registry is also behind this new RMD patient registry that is now being developed within the EULAR Research Centre. So this definitely took on all of the learnings of the COVID-19 registry and aims to be more sustainable in the long term. Any other questions? In that case, I would like to introduce our next speaker, Professor Hendrik Schulze-Koops. He's the EULAR Scientific Program Chair, and he's from the University Clinic in Munich, Germany, and he will talk about the association between air pollution and inflammatory arthritis. Thank you.
Yeah, thank you very much. If it were not for all these acute problems that mankind had, like coronary disease or aggression somewhere else in the world, which causes our attention, we had one big problem since at least the end of the last century, which is air pollution. That causes climate changes, and that may in fact cause also diseases. And there's a global network that actually looks for the outcome of such air pollution on health, and this is called the global burden of disease. And in fact, it's now estimated that about 3.5 million people per year simply die because of air pollution. That has not been seen, of course, some 100 years ago or 150 years ago before the Industrial Revolution. But we have to face the situation that there's something in the air which is not intended to be there, which is not only different kinds of gases, but also different kinds of particles. And these particles can be measured, and these particles can be seen, and these particles can be not only measured and seen, but also recorded. And there's some countries in the world that have wonderful databases where they can actually connect data from automatic recording of air pollution by different particle sizes, and then combine these with people living there in that area simply by postal code that they have actually looked into the database of the authorities, and then they can look retrospectively whether in areas where lots of air pollution was measured, there's an increase of some particular diseases that has not been seen like 10, 20, or 30 years ago. And one of these countries is Italy, and we are going to present 2 abstracts here at the EULAR meeting, where a group has actually looked into more than 80,000 retrospective data charts and has tried to associate the question or the appearance of an inflammatory disease in someone who has lived close to a machine that has collected over at least 6 or 7 years automatically air pollution as defined as particles in the air. And to our really negative surprise in a way, to say, okay, everything is fine in the situation as we live, these people from the University of Verona, they really found that there is a direct correlation between the numbers of small particles and the increase or the development of an autoimmune disease. And in fact, for rheumatology, of course, it's of importance. This increase of autoimmune diseases is primarily in a disease that is our most common disease, rheumatoid arthritis. And in this situation, one would have to say that air pollution, as defined by particles in the air, actually may contribute to the development of rheumatic diseases, in particular rheumatoid arthritis, in central industrialized world, at least in the time being investigated between 2030 and 2020. The second investigation that the same group from Verona did was to look into osteoporosis. Osteoporosis is a situation where the bone does not deliver enough strength for the requirement of the person, and unfortunately, it appears to be the same case here, that higher air pollution is associated with a lower bone mass, which is the definition of osteoporosis, and also statistically significant by numbers of increase of the pollutants in the air. One can find a percentage of increase of the risk of a bone, of loss of bone structure. So these groups from Italy, they looked, as I said, for 80,000 people with autoimmune diseases and 60,000 people with a question for osteoporosis. And they really put the warning and say, hey, if you live close to something that gives you increased and intense and chronic air pollution, you may be at risk for developing musculoskeletal diseases, for example, rheumatoid arthritis or bone loss, that's called osteoporosis. And the third abstract that is deals with air pollution is a situation that is not directly associated with air pollution, but with particular particles in the air, or which we can inhale, and that is silica. Silica, in particular crystalline silica, has been associated with autoimmune diseases, in particular rheumatoid arthritis. But in these situations where this has been done before, usually in men, rheumatoid arthritis is a disease that affects women 3 times more frequently than men. And what these people have now done, these scientists have done, they have looked into the question whether they can find actually the source of silica crystals for those females affected with rheumatoid arthritis. And they have looked for different potential sources and came up with the conclusion that cleaning activities, in fact, so for ladies working in the cleaning business, is a most important contributor to silica that may be driving or at least facilitating rheumatoid arthritis. And they conclude that cleaning activities, dusty clothes laundries, and talcum powder handling will increase the exposure to silica, and that may be part of the pathogenesis of rheumatoid arthritis. And one thing is in particular worrisome is that over the years that we work with these diseases, rheumatoid arthritis has completely changed its appearance. Like 50 years ago, it was a disease that affected the bone and the joints and made a painful erosion of the bones. We don't see erosions that often anymore, and this is not only attributed to the clinical activity of the medication. We simply don't know why this has changed, the development, the dynamic. But what we do see more and more is the involvement of other organs, such as the lung, such as the heart, or such as the vessels. And what these people find is that the silica exposure in these individuals they have looked at is particularly worrisome because it may directly affect the lungs and make the lung a potential target of the rheumatic inflammation. So altogether, once again, if it were not for corona and aggression, which we certainly have to handle, we should look onto the chronic problems that we have, and that is air pollution and whatever is in the air that may not be so healthy as we think and may in fact be part of part of the reason why we do see our patients nowadays, which may not have had the problems of rheumatic diseases if the air would have been as clean as in 1492, when in fact Columbus went into discovered the United States. And I say that not to tell you that I know this, but because before that, rheumatoid arthritis was essentially unknown in Europe. So something was brought with him. And I don't think it's the potato, and I also don't think it may be a virus. I think it's tobacco smoke, probably, which he brought back from Cuba. And we all know that tobacco smoking is something very dangerous because we know since 1993 that tobacco smoking is directly associated with the risk of developing rheumatoid arthritis. So there may be more from the US coming that we don't want to have, and we will figure out the hard way. But in this sense, please be careful what you breathe.
Very interesting. Thank you very much. Any questions for Professor Schulze-Koops? Yes, please.
Hi, I'm John Giever with MedPage Today. The Italian abstracts you mentioned, were there particular components of the air pollution that were responsible for this? Are we talking particulates, or there were other?
They only dissociated them by size. So the 2.5 and 10 usual size. And
you're not talking about the gaseous types of
correct,
pollution?
Yes.
Yeah, okay, thank you.
Any other questions? I don't see them. Okay. Then I would like to introduce the last highlight of our abstracts. Of course, we have many more, but for today, it's on the topic of sexual life and pregnancy and rheumatic diseases. And I'm very happy to have Professor Marta Mosca with us. She's the EULAR Abstract Chair, and she's a professor of rheumatology from Pisa in Italy. And I would also like to introduce already Professor Thea Vlieland. She is the EULAR Vice President for the Health Professionals in Rheumatology. Thank you both.
Thank you very much. Thank you. It's a pleasure for me to be here. If we look at the epidemiology of systemic autoimmune disease, well, we have to say that many of our patients are young women in their fertile age. So reproduction, it's a big issue when we deal with these patients and when we treat our patients. And so at this conference, as always, I would say in EULAR, but particularly at this conference, we have many sessions and we highlighted abstracts related with fertility, conception, contraception, and pregnancy in our patients, but also with an eye to the dead-to-be, because sometimes, because we deal with female patients, we forget fathers. So there are data also on the impact of treatment on fathers and on men. So what we have here is the Meet the Professor sessions. Is not among the highlights, but I want to highlight the fact that we offer the opportunity to our attendees to discuss with the experts about contraception, about pregnancy and issues with treatment during rheumatic diseases. But we also have many nice oral presentations and posters dealing with this subject. Obviously, lupus is one of the diseases that is covered very often because it's typically the disease affecting young women. And we all know that patients with lupus have adverse pregnancy outcomes. So what we find in the program this year are works that come from very large databases. So what is new is the big number of cases that were examined and tell us, actually confirm the fact that patients with lupus have complicated pregnancies, might have adverse pregnancy outcomes, but also, for example, that a low complement at time of conceptions might be considered as a red flag, something that has a bad prognostic value for the evolution of pregnancy. But what I think is also very interesting is that sometimes among rheumatologists, someone might feel that rheumatoid arthritis in pregnancy is not a problem, as well as spondyloarthritis, and it's not true. If we go through these posters, we can see that even if pregnancies in these diseases are not as complicated as in lupus or antiphospholipid syndrome, if the disease is not well controlled, if patients are on steroids, they might have adverse pregnancy outcomes. So I think that this is a very important message for Monday morning when we go to the clinic and we deal with our patients. But as I was saying, it's not only pregnancy itself, it's how the patient behaves during pregnancy. And we always discuss about the fact that the patient has the lead. So when we give an advice to the patient, then the patient is deciding whether they want to follow this. And one issue is adherence to medications. So there is a poster dealing with adherence to medication in pregnant patients. And what the authors have observed is that 25% of pregnant patients are not completely adherent to treatment. You may say it's a low percentage because 75% are adherent, but if you consider that taking medication will help to control the disease and reduce the risk of side effects and adverse pregnancy outcomes, it is not very well. And so it's again a message for Monday morning. Discuss with your patient how it's important to treat your disease always, but particularly when you are pregnant. As far as pregnancy is concerned, fertility is another issue. It's a big question patients ask us. Will I have children? Will I be able to become pregnant? Is the disease impacting on this? Is the treatment impacting on my fertility? And we have data showing that in patients with spondyloarthritis, we knew already from other diseases, these patients have some difficulty in having their pregnancy. And this might be related, for example, with the use of anti-inflammatory treatments because they impact impact on ovulation. And again, it's a very important message we can bring home from the conference. And finally, as I was saying, it's always a female question when we think about pregnancy, is the mom to be, but it's also the dad to be. So what's the impact of methotrexate on the sperma of patients? It looks like from an interesting study that there is no impact. So it might be that we do not have to tell to our patient to stop the treatment when the couple is wishing to conceive. And this is also very important because we never know when the pregnancy will be there. And so with a chronic disease, we cannot tell to our patient, stop, then conceive, and then you take back your treatment for the mother, but for the father as well. So follow the path of pregnancy. I think it will be very important for our attendees, and I'm very happy, as you see, it's something I'm very into because I think it's very important when we deal with our patients in our everyday clinical practice. Thea, I leave it to you.
Thank you, and thank you very much for the opportunity to highlight an abstract from the HPR program of the Congress on behalf of the HPR involved in the Congress program. And before I do that, I want to stress that the HPR track in the Congress comprises a large variety of topics with interesting issues not only for HPR, irrespective of their professional backgrounds, but of course many of the areas are also of great importance for people living with RMDs and rheumatologists as well. And regarding the abstract that I want to highlight, it is one on a currently underexposed area of health that could benefit from more attention, and this is on sexual health. It's a study from Herman Kova and colleagues from the Institute of Rheumatology in Prague, Czech Republic, and it concerns the effectiveness of an 8-week specialized physical therapy program for sexual health in female patients with systemic sclerosis and idiopathic inflammatory myopathies. And why is this study so unique? It's interesting because systemic sclerosis and myopathies are rare, complex, and serious rheumatic conditions. They have not only very important medical aspects, but they have a profound impact on patients' overall functioning and quality of life. And this includes intimate relationships and the impact of diseases on sexuality. And this is seen in daily clinical practice, but was also highlighted in the literature. Now, this study is unique in the sense that it not only identifies a problem, but also evaluates an intervention to support patients in coping with sexual problems related to their rheumatic disease. And it was done by means of a controlled clinical pilot study where the experimental group received a tailored intervention delivered by a physical therapist, with a pelvic floor exercise being the main component. And the control group received no therapy. And it was found that overall the patients in the intervention group improved significantly, whereas patients in the control group deteriorated. And the improvements concerned functional abilities, sexual functioning, and quality of life. And I think these results are very promising, and in particular because they are concerned with an intervention to counteract the deleterious impact of rheumatic diseases on sexual functioning. And this study only comprised 16 patients, and of course a larger study is warranted. But, however, it must be noted that these are rare conditions with usually small sample sizes of clinical studies. And I hope that this presentation raised your interest. And I would like to stress once more that the HPR track in the Congress has many more new insights from recent research. And we also start and finish with overview sessions to guide participants through the content of the HPR track. And we have many poster tours and individual poster presentations to put the work of HPR scientists in the spotlight. I would also like to invite you to visit the HPR booth And this is the hub for HPR interaction, networking, and forming new connections. And here you will be able to get more information on the activities of the HPR.
Thank you very much. Do we have any questions for Professor Mosca or for Thea Vlieland? I don't see any. Okay. Well, in that case, I thank you all very much for your participation, for your interest. If I may, I would like to give the last word to our President, Annamaria, for the closing of the press conference. Thank you very much.
So thank you very much for having attended the press conference today of EULAR. I hope you enjoyed it. You found the items that we presented to you interesting. These highlights are for us very important, but you will find a very dense, intense program, a very interesting program during the Congress. So please visit the different meetings and sessions. There are hundreds of sessions and preeminent speakers who will present really updates and what is new on different areas of rheumatic and musculoskeletal diseases. So enjoy the Congress and stay with us to celebrate the 75th anniversary of EULAR. Thank you very much.